Welcome to Critical Conversation Emergency Medicine Unfiltered. I'm your host, Dr. Nirdosh Rassani, and today I'm joined by an emergency medicine pioneer and a global health leader, Dr. Junaid Razzak, for an honest conversation on evidence in medicine, what it really means, how to interpret it, and how to use it at the bedside. Welcome, Dr. Junaid Razzak.
Thank you so much, Nirdosh, for inviting me. And this is such an important activity you started. And congratulations.
Thank you so much, sir. Let's start with a very foundational, very basic question that's asked by most of the residents and newcomers in emergency medicine. So, what is evidence in medicine?
Right. A definition of evidence is really, as the name implies, is using the previous experience based on research to take care of the patients we have in front of us now. So it is really about learning from the past experiences and outcomes of larger number of patients and synthesizing it for that individual patient we take care of. And that is what makes it so interesting and also somewhat, I don't want to use the word weak, but people have a lot of questions about if we can translate that evidence to individuals, and hopefully we'll talk about that.
Great. You have practiced and led research in both high income countries or high resource and low resource settings. So, do you think the very definition of evidence is biased towards high income or high resource settings?
Absolutely. There's no question about that. The evidence is generated on populations that are different, not just social, demographic, economic. Actually, I feel that there are some significant differences in how our bodies respond to certain treatment and the pathologies and the processes that the speed at which the pathologies evolve in populations in low middle countries is different. So and that's one of the criticisms, right? And I think, as people like yourselves, younger people who are looking at the evidence, start to ask that question: does it apply to our population? And if it does, can we prove it? So, I think the bias is there, and we have to be aware of it and cognizant of it.
Okay, let's start with what do we mean by the evidence question, right? If a case series from a low resource setting or low resource hospital saves a life locally, but it never makes to a high impact journal, which usually happens, is it any less valid than a multinational RCT?
At the end of the day, our commitment is to the patient in front of us, and our um, the years of training we have and everything we do is around how do I improve the quality of life for this patient and the quantity of life for this patient. Now, there are many conditions for which RCTs don't exist, especially in emergency medicine. We do things which are based on years of teaching one after the other. If it works, you should use it. But also at the same time, I would encourage people to test it in larger populations. And I'll give you a couple of examples. When I finished my residency and came back to work in Pakistan, there were some people who were using tranexamic acid for bleeding patients. In emergency, at that time, in emergency medicine textbook didn't really exist. It was like a second, third line treatment. And I remember we used to joke about some of these medications which are ubiquitously being used. And then until we realized that actually there is then evidence several years later that if you use it in certain conditions, actually you can save lives. Similarly, sepsis guidelines, when they came in, and these studies mostly done in the West, showed that, give fluids, 20 cc's per hour bolus, and then 20 cc's again, and 20 cc's again, or for adults, 2 liters. We used to, again, joke about people who were like giving a small amounts of fluids, and till I myself in my own practice realized that many people that we have in Pakistan, at least in the context I was working in, went into volume overload, heart failure, pulmonary edema, and like this almost never happens on the other side of the Atlantic or other side of the world. So I think that understanding, and because we all work in silos, very few people have the bedside clinical experience of the two worlds. So I feel pretty strongly that the evidence that we have has to be tested in your own environment.
Okay, Dr. Junaid, as you just mentioned, it depends on It's not. It doesn't depend on the RCT, or it doesn't depend on the case report. It's basically, if the research, if any research is local research, it's saving lives, it's applicable to the local context, then it should be used, right? That should we continue to teach residents that RCTs are the only gold standards when so much of the innovation has come from the practice first and research later? And this is the tragedy with the research in medicine or evidence in medicine, that the evidence lags behind the practice. So what would you say about it?
Look, we go through years of training as physicians, emergency physician, 5 year of medical school, 1 year of internship, and 5 year residency, 11 years. So in those 11 years, I would prefer that our clinicians and leaders in emergency medicine understand the strengths and the weaknesses of the levels of evidence we have. So I think if you take a overly simplistic approach and say that one thing is better than others, we can perhaps do that for people who don't have time to absorb and understand. But for emergency physicians, bottom level people working, they need to understand that everything has its own place. So RCTs are very, very helpful, and as long as they apply to your context. So when, for example, when we talk about journal clubs and studies, we talk about internal validity of an article, the external validity. And when we talk about external validity, we mean that what if this study that was done in a X context is applied external to that context? In my context, is it still valid or not? That's where we need to be. You're one of the leaders in emergency medicine in Pakistan. That question may be at an individual level, but it's very hard to do that at an individual level. But at a group level, one can ask, this has been the recently published RCT on this. Should we practice it in a Pakistani context or in some other context? And that's the peer group, a peer review that we need to have in the local context. So again, I don't think we should say one way is better than others. But what if the question is, I don't have an RCT, which is what 90% of our practice, or
Definitely.
I have an RCT which is not valid, external validity doesn't exist. And I think in that case, we say, okay, what else exists? My personal bias is that the peers review is very, very important. So if 10 experts in emergency medicine get together and say, look, we don't have a clear gold standard evidence, but can we still come up with some guidance or guidelines based, and then describe the strengths and weaknesses of those guidelines? That is, even I think, gives the next best, or perhaps one of the best ideas and pathways for us to move forward in practice. So that peer review process, guidelines locally, and some countries are doing better than others. I think in Pakistan we have struggled, but I think there's enough people now who can do this.
Great, sir. Okay, so if we talk about evidence and conflict, so my question is, what do we do when evidence and the patient values collide? For example, a family refusing for a guideline based care. What do we do? What is the way forward?
We work for the patients, and patients come to us because they think we are experts, and they expect us to tell them what are the options and what amongst those options have the best potential outcomes. If I know that a certain thing, a surgery, a procedure is more likely to help the patient, it is my responsibility to tell that to the patient and the family. But at the end of the day, and again, I'm coming from the Western biomedical ethics mindset. At the end of the day, people choose what they want to do. Unless some people might say, well, what if it's going to harm the population? What if there's a patient with a disease that could spread to others? Could we intervene? And that's a more societal and government question. But I think at the individual level, what I would do in a situation where there's a conflict or disagreement on the therapeutic approach or diagnostic approach to a problem is to do an intervention called chair, pull a chair, sit down and talk to people and tell them why you are saying certain things. 9 out of 10 times, people, when they see that you are competent and confident and you have patients' interest in mind, they would agree to that. But if they don't, we still have the responsibility to provide the best care we can provide within the boundaries that the patients and their families have put around us. So I would not fight. Uh, Rarely would I say that it doesn't make sense. Also, look, at the end of the day, if it was my family, I would do something different. If it was me, I would do it differently. But if you don't want this care, and as long as you understand the potential consequences, we can go the other second best route as well. And I think it's a really interesting part of emergency medicine, right? We deal with real humans, and real humans comes with their own background and their own experiences, and often a lack of trust in the system.
Yeah.
Fortunately, that's true to some extent as well in our system. But if you tell them, and I've done this many times in Pakistan, I say, it doesn't make a difference to my salary what you do. There's no interest of mine. I don't make money off this decision. I would, if it was my mother, it was my sister, my father, I would do this. And often I've been able to convince people.
Great. So I would like to share my experience here in Quetta when I started working here. So the Quetta, the population of the Quetta, the ethnicity is totally different from Karachi. So there was a case, there was a young lady who suffered a cardiac arrest, and my team started doing the CPR. And the husband, he rushed inside the resus room and he tried to stop all of us. Why the hell are you touching the chest of my wife? So, these kind of situations, push you and push you to think about the right and wrongs. But I think the right decision at that time was to do the CPR, continue the CPR. We did that. So sometimes, we have a wall in front of us because the guidelines and the evidence, it's not so straightforward sometimes. That's my take on it. I don't know if you agree with it or not.
So, several times this happened when there was a staff member of the hospital at AKU whose daughter was in a road traffic crash, and he brought the child, a young girl, in her teens, and she was very sick. She had significant trauma, and he came from a conservative part of society, and he felt that he will not allow a male person to take care of her. And I tried to explain, and he won't. His pretty fixed views, which I was quite upset at that time because he was the staff at the hospital I was working at. But I also understood, what we were able to do is to say, can we get women to provide care as much as possible? The issue was not her getting access to care. The issue was for that family, in your case, maybe also, was that they wanted a gender appropriate care. And I respect it. And you won't believe it happens in New York as well.
Okay, so let's move forward towards the very interesting myth busting evidence misconception segment, and we do it in every episode basically. So let's start with the first question and first myth. That's only RCTs matter. Everything else is weak evidence.
That is a myth. RCTs are at a higher level of science and evidence, but other evidence also matters.
Great. Guidelines are all.
Can I just?
Yeah, sure,
Yeah,
sure, sure.
sorry.
You can
Yeah,
go ahead.
yeah. The evidence, for example, for association between smoking and lung cancer, the initial studies were all case control studies, not even cohort studies, because the type of disease it is. Uh, and it was many, many years later. You can't really do a randomized control trial for smoking and lung cancer. You can't make people smoke and say it's going to be having lung cancer or not. There are many so and many other conditions which have rare outcomes. We start with a much lower level of evidence and we use it very strongly.
Okay. So the second myth is basically guidelines are always evidence based and should be followed blindly.
They are rarely, if you look at the guidelines documents, they will define the strength of evidence as part of the guideline process. And you will see that, many a times some recommendation would come out, even though the evidence is not very strong. You were asking me all guidelines based on RCTs and strong evidence, and I was saying that many, and actually I would say most guidelines have material in there which are not based on the strongest evidence. It doesn't make them less useful. It's just that the science either doesn't exist or doesn't apply to the context. So again, I would say what I did before, that it is the responsibility of you as an expert in emergency medicine to be able to say, well, this evidence works for me, this evidence doesn't work for me. I need to get more specific evidence for the population I'm working with.
Great. So this is a related question to the last question I asked you. Case reports are just anecdotes. What do you say about it?
They are, but um, there many great inventions happen after somebody did an experience or with one patient or a series of patients. So while one can again say that, can I apply this single patient story to my patient? One has to say, well, this may be applicable and others may not be. Like I'll tell you example for there was a this month, I think it's Annals of Emergency Medicine, where they're talking about people coming in with cardiac arrest in following a heat exposure. And this is a small group of patients. And they said, we actually tried to reduce the temperature while doing CPR. It's interesting. I was thinking, there's no RCT for it for now, but I may see this patient somewhere. And could I use that evidence if it improves the chances of the patient to survive? If the survival is going to be 0%, if I can make it 5% with this intervention, I'll do it.
Okay. And the fourth and the last myth today we'll be busting is if it works in the US or Europe, it must be the gold standard everywhere. Let's take it this way. Is it fair to call something gold standard if it's unaffordable, unavailable, or unsafe in most of the world?
So a gold standard is a gold standard in the environment it was created. A gold standard, if it is harming patients in another environment, then obviously it is not acceptable. But I also come from a little bit of different philosophy on this one. All of these questions are great, but there are nuanced answer to that. I think everybody deserves the best quality care in the world, irrespective of where they are. And I will not just throw away evidence if I feel that it's a good evidence for my population. But I will understand that if my system can't afford it, what is the second best thing I can provide? As a clinician and as a person who has some say in the policy making, if I'm convinced that my patients will benefit from, say, stroke patients benefit from thrombolytics, even though it is expensive, I would still advocate for it. I think our patients need it. If they can't have it, then I would think about what can I do to improve the chances of survival if they can't get the gold standard. So I will not just trash a gold standard just because it is not produced here, but there will be many so-called gold standards. For example, a lot of things that we do in EMS in the US, which has no evidence basis. In those cases, I would say that's not standard for me. I'm not convinced.
I think we should move forward towards the next segment, and that's how can we bridge research into practice. So my question is, why do we keep producing research that never changes bedside care?
So research is an industry, and
Thanks for saying that.
it's a huge industry. I'm part of it. We have created this industry because we have expected our academic clinicians to publish, and so we created a market for it. Right? If you talk about in the economics term, there's market for it just because you need it for promotion and all of that. And we all play this game. We all publish it. But in your lifetime, if you can do one or two things that will change the practice, then I think you've done your job as a researcher. And most people actually don't change practice at all. So the reason, to answer your question, the reason we do it is because there's industry and there's a demand and there's a market for it. Ideally, we should also try and look at, are we making an impact? And more so, I think people are expecting clinician researchers to prove that they've had either an impact in policy or practice.
That question came in my mind because whenever I see $1 million grants are being given for research questions that are so vague or preliminary, that's why that this question came into my mind. So let's move forward to the other question, the next question in this segment. That's what's more dangerous, practicing without evidence or clinging to outdated evidence?
Oh, wow. I think practicing without evidence is more dangerous. The expectation from us as clinician is that patient expect from us that we know our business, and we know our business by reading about it. And that's why in many societies or many specialties, you have to have recertifications because science, evidence, practice changes. But if you are adamant and say, look, I know what is right, I have been practicing for 40 years as a professor of medicine, this is how I do things, I'm against that. I think we should try and keep ourselves updated. And if you can't, then hopefully you will have some background evidence. And even you can't do that, then You're practicing only the art of medicine, not the science of medicine.
So let's move forward towards the segment that I call pitfalls and bias in research and interpretation of the research. So, how much of modern medical literature is truly free of conflict of interest?
All of us as humans have biases. We cannot be 100% objective. It's very hard to be 100% objective. We sometimes the important piece is to realize what my biases are and to share my biases as a researcher with my audience. It's part of the limitation, part of the discussion of my finding. If I'm not doing that, if I'm not sharing the biases, then I'm working not for my patients, I'm working for an industry. Right? I'm trying to get the outcome, the result that I want and what the science says. You have to understand, science is about objectivity. And that's why we say it's science, because if I was trying to prove what I already knew and find methodologies and systems that will get me to a conclusion that I started with, then we are not scientists. Then we are, using science to get to our own objectives. Now, if I'm doing a study and if I have bias, then I better declare it. And that's why we declare it before our talks as a conflict of interest, and that's why we declare it as when we submit papers. But it still exists. And what you're seeing, it may not impact obviously Pakistan, but we're seeing in the US anti-science bias is because people are saying, you talk about science, but actually you guys all biased. You tell us what the industry wants.
All right. So this is more or less related to the first question. If industry funds most of the trials, how do we trust that evidence is not just marketing dressed as science?
Yeah. You have to understand the science yourself, and often you don't. You don't have we don't have time to read through all the papers and discuss them and find the methodological errors in them. So we've created these systems in science called journals and peer review process. Now, if there's a New England Journal article, if there's a Lancet article, you feel that these guys have done a good job with objectively assessing the science using the right peers who know the science themselves and who do not have any conflict of interest. So that's why you sort of trust these high impact journals. And so that's my first thing to see. I say it's a New England article. Then I look at who's publishing it, and then I look at who's funded it. Now more and more people are saying, what was the involvement of the funder in publication? If funder is involved in data analysis and reporting, then there's a big problem. Now you have to understand, everybody have their own angle. Their angle is to make profit. That's fine. They're open about it. My angle is to provide best quality care to the patient. If there's a conflict, I need to know this. Sometimes there is none. They just fund the research and they declare that we are not going to be part of any of the data analysis or data reporting. I still take it with a grain of salt, but I'm more open to looking at it. So, if it's totally funded by an industry and it is published with the co-authors from industry, I would take it. I would really look at it suspiciously.
Thank you, Dr. Junaid. Now I run a segment that's basically advice for trainees, guidance for young clinicians and the researchers. Trainees are told to practice evidence based medicine, but with thousands of new papers every month, is it even realistic?
It is not realistic for you to read everything, especially in emergency medicine. Our breadth is very wide. We do a lot of things. There are two or three things you can do about it. If you have large enough faculty or residents, then start to develop areas of expertise within your group. So you may get a person who's focusing on, say, cardiac emergencies, and they're spending their time and their lifetime reading about this, and they become your local expert. They might be somebody on trauma. So that's one approach to it. The second is there are enough people out there like yourselves who are doing public service by getting experts to talk about certain aspects of emergency care, synthesizing that evidence or the practice. So that's the other piece. And if your program, your podcast is funded through some industry, then you will talk about this and say, look. But if you're coming from the point, I saw this gap and I want to fill that gap and I want to improve quality of care, then there are a number of these options available. And then finally, I tend to follow two or three journals, and so regularly, New England Journal of Medicine, Lancet, Annals of Emergency Medicine, Academic Emergency Medicine. There are four journals I tend to follow, and rest is podcast.
Thank you so much for endorsing this podcast. And this is the time to make a disclaimer that this podcast is not funded by any pharmaceutical company. So, Dr. Junaid, it was Nice talking to you, and we have unpacked not just what evidence is, but also we have busted certain myths and certain limitations we have discussed. So, to our listeners, remember, in emergency medicine, every decision counts, and the right evidence can make all the difference. So, Dr. Junaid, the last message to all the emergency medicine practitioners in Pakistan, you want to give a last message?
Yeah, yeah. We are a diagnostician. A lot of what we do is diagnosis. We do we don't do a lot of treatment. Our treat our treatment options are limited. Our diagnostic challenge is big. To the young emergency physicians, I would say that use your time and energy to look at the current diagnostic processes that are so-called gold standard and study them. If you're doing a CPSP synopsis, do it on heart score or well score in Pakistan and see if they apply. Add to the science. I think it will be very, very helpful. Thanks.
Thank you so much. It was you know was a privilege to talk to you and talk about certain very challenging conversations which we are not doing it on the usual basis. Thank you so much, Dr. Junaid.
Thank you so much. Appreciate it.